We're going to do our indications conference first. So, Eric, go ahead and kick us off.
So this is a 44-year-old female who has a left fifth metatarsal shaft fracture after falling down some stairs on Memorial Day. No significant or relevant past medical history or past surgical history. On physical exam, there is bruising and swelling noted throughout the lateral aspect of the foot, and she's tender over the fifth metatarsal. Um, we only had two X-rays, unfortunately, from the outside facility. We have this AP ankle X-ray, which does show the fifth metatarsal shaft fracture, as well as an AP foot X-ray that again shows it. Kind of a light weak on the south rotation, but this kind of is an interesting one. Just because most fifth metatarsal shaft fractures, outside of our Jones fractures, and even those we mostly non-op. But plan is for ORIF of this fifth metatarsal shaft fracture, just given the amount of displacement. So not necessarily much to talk about here, but did just want to present it.
Yeah, this patient I didn't see yet. She was seen by Steven, Dr. Metzel's PA, on Friday, and they reached out to me if I could do it this week. So she's seeing me tomorrow. So I mainly just wanted to get her on the schedule and get her a spot. But we'll get foot X-rays tomorrow. I'm guessing there's probably some plantar displacement, which is a thing that probably would lend this towards surgery rather than just the displacement here on the AP view. But we'll kind of see what it looks like tomorrow.
Yeah, that's kind of the reason why I presented it, honestly, because I knew you hadn't seen it yet, and we didn't really have good films. So, this is kind of one of those that could go either way. You could fix it, but I think more often than not, you probably non-op it, but we'll get full X-rays and see.
So, Eric, what are your indications to fix a metatarsal shaft fracture?
Well, I mean, a fifth, there's very few. I mean, think about, even though this is a short oblique fracture, your intermetatarsal ligament is going to hold it out to length. You don't really worry about this shortening much. Whether it's classically the dancer's fracture, those always, they look horrible. And then you non-op them and invariably they heal. So really, I mean, not many surgical indications for your fifth metatarsal shaft fractures.
I think if it's really short, which to your point would be hard because the intermetatarsal ligament's intact, or if it's really rotated. Those are the two. So if you're looking at that fifth toe and it's rotated out relative to the other side, but yeah, that's this fracture. Yeah, this fracture will heal fine. The question is the patient going to be happy if it heals in this position? So, but yeah, obviously, weight-bearing X-rays and exam goes a long way.
And we will complete that tomorrow. But yeah, so that's kind of why I wanted to bring it up, since we hadn't really gotten a full workup on her. All right, and then let me present this post-op. So Dr. Metzel post-op from last Wednesday. This is a 64-year-old male who was biking 3 days prior to surgery and suffered a right tibialis anterior tendon rupture. He is a high-level mountain biker and a retired orthopedic surgeon who is very familiar with tibialis anterior tendon ruptures, both from his practice, but also his personal experience, as he had a left tibant tendon rupture back in 2020 that was primarily repaired by Dr. Metzel. And kind of wanted to mention on there, his left tibant tendon repair was not accompanied by a gastroc recession. So on physical exam, he basically tore it on Sunday. So he lives in Durango. Saw Dr. Metzel on Tuesday. Was noted to have 0 out of 5 ankle dorsiflexion strength. You could not feel the tibant with attempted ankle dorsiflexion, and was clinically diagnosed with a right tibialis anterior tendon rupture. So here are his AP, mortise, and lateral X-rays from Tuesday. And then he got an MRI the same day. Perks of being a retired orthopedic surgeon who is close friends with Boblik. A lot of stress. There's a lot of stress. You can see the bone marrow edema within the calcaneus. So he did suffer a pretty significant injury, large ankle effusion. And then on the sagittal, you can better appreciate the tibialis anterior tendon rupture, kind of right at that classic location below the extensor retinaculum. So we underwent a tibialis anterior tendon repair. This was a primary repair. This is the second one we've done in the last few weeks. So it's kind of interesting just to kind of do two back to back, just to see kind of what the differences are. One of the cool things about this surgery was that since we got to it within 3 days, it was fresh enough that I remember when I was marking out my incision, I marked out my incision a little more proximal, and Dr. Metzel was like, "Oh, we're not going to need to go that proximal," because I was thinking about trying to fish out the proximal retracted stump. He was like, "It's not retracted," and so really I made just kind of like a 5 centimeter incision centered over the medial cuneiform, and really just kind of dorsiflexed the ankle up, and there was the tendon stump. So getting to these as quickly as possible is really nice. The tendon stump, whether it's an Achilles rupture or a tibant rupture, me and the free are like best friends, and I love to really try to break up the adhesions just to mobilize the retracted stump. Really didn't have to do that as fresh as this was, which was really nice. I really think helped us set our tension because we did not do a gastroc or an Achilles lengthening on this patient, whether it was last Wednesday or, like I said, in 2020. That made me nervous personally, but one of the things that I learned from Dr. Metzel is that in high-level athletes, they'll hate you if you weaken their calf. So certainly getting to it fresh kind of helps hedge against that. And then the other thing too that I kind of took away from this case was fiber tack versus suture tack anchors. We started with a fiber tack and it pulled out, and Dr. Metzel didn't note that has happened to him in the past. So I think one of my takeaways from this case was just going straight to the suture tack anchor.
It's interesting.
Yeah, it pulled right, and he kind of predicted it would.
But why do you think that is? Did you have it in the cuneiform?
Yeah. So I don't know if it's just the cancellous bone, if it's the bone density or whatever, but it pulled out.
I've never really thought of like a suture tack as superior to a fiber tack in terms of pullout. That's interesting.
Yeah. So yeah, I don't have an explanation for it, but like my daughter would say, I don't have a reason, but that's what it is. Cool. All right. And so I guess I'm gonna save that last pre-op for when Dr. Metzel's on, because he's gonna want to talk about that.
Yeah, that sounds good.
All right, I'll stop my sharing.
I'll take over. Dr. Moon's out this week, so I'm going to be hanging out with Dr. Jameson tomorrow. So I have one of her cases, and then I leave for Namibia on Thursday. So a little bit of a short week on the north side as well. This is a patient DF. This is Dr. Jameson's 58-year-old female. She was on a full four-wheeler, came off, and somehow it was like accidentally not on park and rolled over her ankle on the 27th. She had left ankle pain. She's otherwise healthy, normal BMI. These are her x-rays here from the ER. And then she was referred to us with a CT scan. Go through this. Just kind of pause there just to highlight the part to talk about. So trimal ankle fracture. She has a very small cortical like Chaput fragment that also has like this like intra-articular basically impaction there. She's 58. She's pretty healthy. So I think our plan, based on looking at the surgical posting, correct me if I'm wrong, Dr. Jameson, is to go ahead and fix that from the back, maybe a posterior lateral approach, go back to fix the fibula, and then a separate incision here for the medial mal. I know Dr. Hunt, we've had trimals that are kind of minimally displaced, and this one I think is pretty minimal as well. And I just kind of wanted to clarify on criteria for you guys, like when to go after that piece in the back versus leave it. Obviously, we know the Chaput fragment confers more like stability for the syndesmosis for that PITFL fragment, but definitely some morbidity with doing some of the posterior approaches. So just wanted to get people's thoughts.
Can you show the lateral X-ray?
Yeah.
I mean,
we don't have a great lateral without her plantar flexed. But,
okay. Yeah, I think, I mean, this seems like what's most important is getting your fibula out to length and correct the rotation. And then I look at it as you can either reduce and fix the posterior mal or you can stabilize the syndesmosis. The reason the CT is helpful is if that posterior mal really gets into that incisura, into the syndesmosis, then I think you have to fix the posterior mal because reducing the syndesmosis could pop the fibula out the back.
oh, I see.
So this is kind of a tweener, but I worry a little bit about what the stability will be like posteriorly, and if you cinch down, your syndesmosis is going to slip out the back. But I also worry about managing both of those fractures through one incision.
Yeah, fibula is pretty high.
But there's some impaction there on that sagittal view. So yeah, I mean I think I would reduce and fix the posterior mal. Probably just needs, I mean, you need to reduce the joint and you need to probably just throw a screw or two in it. Maybe a plate if you feel like it's big enough. Hard to tell here.
Yeah, my plan was to definitely fix the posterior mal. She was kind of subluxated posteriorly at the back too. So when I see that, I'm for sure gonna fix the posterior mal. For something like this, I might actually try to kind of reduce the fibula first, because I feel like that might help us ensure that we don't mal-reduce the syndesmosis with that posterior mal fragment. But I was gonna address both for sure in this.
I know typically we don't like fibular hardware initially just because it blocks the X-ray visualization. Is everyone going after trying to do the fibula reduction first, just like temporarily hold it with K-wires or something else?
That fibula is so high too that I don't think it'll be an issue in the posterior mal is so low.
Yeah.
So yeah, we can either do it through one big incision. I kind of hate the posterior lateral approach, to be honest.
Okay.
With that really high fibula, so I might do kind of like a mini posterior lateral incision just to put a screw across that posterior mal and then just go to a lateral fibula.
Yeah, I think that's the right call because if you're not going to plate it, you don't have to go that proximal.
Right. Yeah.
And then you can cheat a little anterior with your fibula incision. I think that's a better way to do it.
Yeah, that would be my plan.
I've watched, I don't know if you guys get these emails from ViewMedi, but there's a group out of Liverpool, this guy, Lyndon Mason, who has probably written the most recently about the posterior mal. And there's some really good videos where he goes through the rationale of why he fixes them, the various approaches. And he also, notes that even when you fix that posterior mal, it doesn't necessarily completely stabilize the syndesmosis. It improves the chances you won't have to fix the syndesmosis, but you often fix it posteriorly, and there's still some anterior fib instability that requires a screw or a tightrope. So I just highly recommend for anybody looking up Lyndon Mason on ViewMedi and watch a few of his videos. There's also, he has stopped doing the posterolateral and he has this posteromedial that's right next to the Achilles. He has a medial posteromedial that kind of goes through the posterior tib or FDL tendon sheath for different patterns, and he kind of goes through which patterns he uses what for. But that might be a good approach, is to go medial to the Achilles, and you can stay away from the neurovascular bundle, and then make a lateral incision to do the fibula.
Dr. Kleeman, are you supplementing all of your trimal fixation then with syndesmotic, like you doing screws or a tightrope?
No, definitely not. But he does note with certain patterns the percentage of ones where the syndesmosis is still unstable. So I do always check it after I've put in my hardware. But I would say I probably less commonly than put syndesmotic hardware in there. Rarely.
I think, I mean, in theory, if the bone failed, the ligament's intact. So once you reduce the bone, you may not need it. I mean, I think putting a couple of tight ropes or even one is probably not a bad thing, just to make sure you buy your reduction and it won't, impact your rotation or anything. But yeah, I mean, theoretically, if you're fixing the posterior mal, you don't have to stabilize the syndesmosis. That is stabilizing the syndesmosis.
Yeah, I'm definitely a little bit more thoughtful about when I put in tight ropes with Dr. Grimsher, and I had that peel on that displaced after we put that tight rope in. So definitely trying to be a little bit more thoughtful about putting syndesmotic fixation in.
Yeah, it's a bit of a different situation, but
yeah, for sure.
But yeah, good to be thoughtful always.
Yeah. Okay, this is a patient, Dr. Hunt's JS patient for Wednesday. She had a history of a lapidus from Dr. Coleman outside hospital in June of 2022. She's had persistent MTP, like in PIP stiffness and pain since that time. She has decreased passive range of motion of her first MTP and PIP joints. You saw this patient with Lisa, Dr. Hunt. Oh, cute. She comments on like active firing of EHL, FHL proximally, but no palpable active motion distally. So I don't know if like both EHL and FHL are tethered somewhere along that first metatarsal or first MTP region. But these are her weight-bearing films from our clinic. You can see she was like basically post-op changes of like the Lapiplasty system with a crossing screw, and her first ray is pretty elevated, and her MTP is flexed here. Kind of going through her CT scans, I just had two of the more pertinent cuts here. You can see she's healed through that lapidus osteotomy, and then here on the sagittal, you can definitely see some first ray elevation, and her MTP does not dorsiflex to neutral. So kind of trying to parse out her exam and her x-rays here. Our plan is to do a removal hardware revision lapidus with a plantar flexion osteotomy, EHL decompression, and MTP arthroscopy and cheilectomy. My question, her first metatarsal isn't super long. I'll go back to these x-rays so we can all look at them together here. But instead of doing like our typical plantar flexion lapidus where we use a dorsal opening wedge, would there be consideration to using like a plantar based closing wedge in order to decompress the first MTP, noting that she has like both EHL and FHL contractures? Or do you think like just in like doing a tenolysis of both of those tendons would be enough to kind of release it?
No, we 100%. I mean, the main issue here is the dorsiflexion.
Right.
So yeah, we 100% have to do a plantar flexion closing wedge. That's the
no. So I'm sorry.
Plan.
I was just basically asking, instead of doing a dorsal opening wedge, doing a plantar based closing wedge instead.
Oh, for sure. No, I would absolutely do a plantar based closing wedge and not a dorsal opening wedge.
Got it.
Because you don't want to make it longer, right? You want to shorten it if anything.
Yeah.
And by plantar flexing, you don't worry about transfer metatarsalgia. Like it's a pretty long first metatarsal anyway. So yeah, I would absolutely do a plantar based closing wedge to kind of shorten it. And then we'll scope the joint to try to free it up. And then I think her tethering is really EHL because she hasn't been able to move that hallux past. I mean, that's not even neutral. It's like -5 degrees, and it's kind of stuck there. And so, little cheilectomy. I'd rather avoid an MTP fusion when there's a TMT fusion. And so we should be able to get some motion through a cheilectomy and kind of get that first ray down where it's supposed to be.
Do you do anything formally with like FHL? Do you think that's a component of the contracture?
It's a good question. No, I mean, not typically, no, just because it's not an easy tendon to get to, but I guess we'd be prepared for that. So if we do free everything up dorsally and it's kind of truly FHL tightness, and how do we determine that? How do we know whether the FHL is tight?
Well, that's what I was concerned. I mean, I don't know how much of this is MTP stiffness or not, but typically on exam, with non-weight bearing, you'd be able to mobilize the first MTP much more if it was FHL involved. And then once they weight bear and engage and the first ray elevates, you have that more fixed MTP flexion.
Yeah.
But for her, because she has, it sounds like like a synovial component of this stiffness, kind of harder to elucidate preoperatively.
Yeah, I don't know that it's synovial per se. I think it's mechanical. That lateral view kind of tells the story. Her first raise dorsiflex by, I don't know, 15, 20 degrees.
Right.
And so she can't clear. In fact, we'll see, like, the dorsal part of the joint's going to be really worn out, but the plantar part won't be.
But that should improve when she is supine. It doesn't sound like, at least, I don't know, I haven't seen her, you can correct me. When she's supine, it doesn't move at all either.
Yeah. So what's the test called that you describe? So basically, if you allow the ankle to be free and kind of rest in a plantar flex position, and we do the kylectomy, everything in the toe moves, versus we simulate weight bearing. So it's like they're standing on something and it won't move. What's that test called?
The Jack's test, isn't it?
Nice. Well done. Yeah. So I think, and we'd be prepared for it, but there's no reason with this procedure and this problem to think that the FHL is going to be an issue. Usually the contractures of the FHL are almost always because of like distal tibia fractures around the muscle belly. I think the tendon is going to be fine, once we get it moving.
Gotcha.
So, and we're going to shorten it a little bit, right, with our plantar flexion osteotomy. We're going to clear the dorsal part of the first ray and get it moving. So I even if it's tight, I'm going to let her rehab to kind of get that FHL stretched out. And I've never had to do that for whatever it's worth, although this is an uncommon procedure.
Cool.
Okay, do you mind, Ro, just maybe make sure they're going to have the drivers for that. It's a unique driver.
Yeah, the Lapiplasty for sure.
System, yeah. Thanks.
Yeah.
I can't really tell what that screw is. I don't think that's their screw.
This one?
Crossing screw.
Yeah, that I don't.
I don't know if we have the op report. I don't know where this was done actually.
I don't know. I didn't recognize the name. It's KUHLMAN. I can see if I can find in more detail. I'll work on it.
All right, thank you.
Of course. And last, here just a post-op. This is a patient SB. Dr. Hunt's. She had left foot pain, primary lateral column, and medial ankle. We went through this weeks ago. Cavovarus deformity. Did this at Anschutz a couple weeks ago. And so our plan was to likely do more like soft tissue work, just kind of looking at her x-rays. And then kind of when we got intra-op, she was pretty rigid. So we ended up doing a triple perc Achilles lengthening, anterior ankle debridement. We were initially planning on arthroscopic, but we were right there when we were trying to mobilize some of the soft tissues. We took off the large dorsal talar spur open, did a plantar fascia release, did a calc osteotomy in addition to that subtalar fusion, and posterior tib transfer, cuboid, longus brevis, first metatarsal dorsiflexion osteotomy, and a fifth metatarsal exostectomy because it was still prominent on the plantar aspect of her foot after correction. Pretty nice. Oh, we also took iliac crest for her, but
I think I think it looks good. We're a little bit distal with that first ray osteotomy.
Okay.
And that was my fault. I mean, it still functioned fine. Like the balance of her foot's really good, but just looking at the X-ray, I wish we were a little more proximal with that.
Okay.
I think we could have been. Yeah, this was, this was. Oh, go ahead, please, Jay.
I was say why post tib to cuboid as opposed to lateral cuneiform?
She had so much supination deformity.
Yeah, it's just a little bit more powerful to correct that supination. We want to move it as lateral as we can. The other reason is that we already had an incision there, and it was a pretty big incision. We didn't do our perineals through a separate incision, but
and there was enough real estate.
Go ahead.
I was going to say there was enough real estate in the cuboid with the staples that you weren't worried about bone tunnel.
Yeah, we went distal to our staples.
Yeah, there was plenty of space there distally.
Okay.
And so we already had that incision there. So rather than then make another incision that's was sort of uncomfortably close to our lateral incision. We just stuck it through there. I also, so I had a really long conversation. This patient was from New Mexico. I'd actually referred her to uh, Glenn Pfeffer, who is like, I mean, I would say not arguably, he's the most experienced CMT surgeon in the world, probably. He said he's done over 1,500 cases. And so I'd actually said you should go to see him for a second opinion. She sent her images, but never followed up with them. So I told her when I saw her for pre-op, I called Glenn and kind of talked through it. And obviously I've learned a lot from him, and we approach things very, very similarly. But he said he'll always put the post tib in the cuboid because you want more lateral pull than anything. And so it was just, I don't know, it was a good conversation. And what's interesting is we went into this, and when we get these younger, this is an older patient, so she's had a lot of time to stiffen up and kind of get stuck in this position. When we do these in younger patients, particularly like teens, early 20s, when you do that post tib release, oftentimes you can do the whole correction, right? Like when we're doing these in teenagers, we rarely do osteotomies and never do fusions. Maybe a calc osteotomy, but for the most part, it's just getting rid of the pull of the peroneus longus and shifting the pull of the posterior tib. But when we released the posterior tib, we did a pretty aggressive, not just a plantar fascia release, but like a release of all those tissues off the calc. It barely budged. It was sort of disappointing. So we sort of knew from the beginning we're gonna have to do everything. We're gonna have to do the subtalar fusion, the calc osteotomy, and basically the triple. But it turned out well. I think it looks good. The ankle's relatively preserved. We didn't have to do anything there. The big spurs that were in there we removed open through that when we did our TN fusion. So I thought it was pretty good. All right. Big day, Ro. We got 3 total ankles.
Yeah. I'll run cases with you the time later today.
That's perfect. Thank you. All right. Very good. Well, thanks for that review. And again, I want to welcome Mike Khadavi, who's very kindly agreed to be our multidisciplinary speaker for today. I've known Dr. Khadavi for a long time. So he was a PM&R fellow at Stanford. And so we worked together with CU football probably, right? Are we at the Niners or CU? You're muted there, buddy. Sorry.
Stanford. It was the football team, mainly the football team.
So we worked together a lot. He's great. Yeah, I knew he was great back then. Now he's killing it in Kansas City, where he's partners with Casey Doan, who many of you may remember as one of our graduates from, I think, 2 years ago, and then he trained up in Vail, and now he's in Kansas City in Mike's group. So Mike, welcome. Thank you for being here. Mike's going to talk to us about ultrasound in the foot and ankle. He actually recently gave me some very good instruction, and I thought this would be a nice venue to kind of go through the latest and greatest. So Mike, take it away.
Well,
thanks for being
you.
here.
And for those who know Casey Dunn, I just dropped off food for his house on Saturday because he had his second baby, Stella. So send him a holler. He is a total stud. Thanks for training him. One of the best hires we'll probably ever make. That man, he is killing it in all the good ways. Before I start, I know this is quite an ask, but could you guys, whoever is able to show your faces, if you're in an embarrassing place or didn't have a bad hair day, don't, but can you just pop up your face? I'm going to start with just a brief discussion before we really get moving. And what I'd like to know from everybody, what I really like to know is who's who. Trying to pull up the view where I can see everybody here, but can you put your hand up if you are a foot and ankle surgeon? Super. Who's an athletic trainer out there? Physiatrist? What is everyone else? So a few of each.
Yeah, we've got some residents, a couple of fellows. I don't know if they raised their hand on the foot and ankle surgeon part. several of our podiatrists, a couple of PM&R folks who aren't on video, PTs, orthotists, APPs. I think that
Excellent.
covers
Yeah,
all the
Dr. Spiller
categories.
just messaged. Yeah, I've heard your name before. I know who you are. Okay, awesome. Well, that kind of helps me know who and how and what my audience here when we're giving this talk. I love foot and ankle, and that always sounds a little creepy when I say it.
It's not creepy at all to us, man.
To this group, right? Well, I'm a consultant for Arthrex, and my other disclosure is I like feet in huge part because of Ken Hunt during my fellowship year. Not only was he a great teacher, but he was the one guy that would bring in a cookie or a muffin during clinic, and that went a long way. It's one of those few memories I still have from a fellowship where I didn't sleep. With and then Kirk McCullough is my partner. If you haven't heard his name, totally awesome guy. I've been working with him for sporting our soccer team and the ballet since I started, and he's taught me so much foot and ankle stuff. So ultrasound in foot and ankle is arguably my favorite body part to scan for a ton of reasons. It's shallow, which means you just get these really clear views. And then the diagnostic and the interventional use of ultrasound has become something that I've just really enjoyed researching and teaching. I have lots of ongoing projects, and it's for the same reasons. They're very successful, both for diagnostic and for procedural interventions. I have strong opinions about this topic. Everybody who has at least 5 years left in your career should be learning ultrasound and getting really good with ultrasound. It's a steep learning curve, and the better you get, the better your career gets as far as doing diagnostics and these things get really easy to do. So the diagnostic value, here are just a few pictures. There's a flexor tendon with an effusion. There's a partial plantar plate tear. These things get really easy to see. And then the dynamic value of ultrasound, this is a subluxing second metatarsal. The dynamic value is something that doesn't exist with any other imaging modality. Procedural guidance, so I have 4 foot and ankle surgeon partners in my group of 40 of us, and they all do their midfoot injections this way. So you can get rid of your mini C-arm with your midfoot injections. And your pictures are so crystal clear with ultrasound once you've learned how to control your left hand and your right hand. And your procedural guidance for injecting anything that's in a tendon, this is a plantar fascia PRP, which is above 90% success rate if it's in the right hands. You don't just take a guess on where you're going, and then when you inject, we pepper it throughout the entire tendinopathic region. And so outcomes data is lacking, but appears to be way better in my experience. So this is a bone marrow concentrate for an Achilles partial tear. There's the Achilles. This is essentially an axial view. That is the area of tendinosis. And then these are the partial tears. And so there's no guesswork involved in where my needle is going. I can pepper my bone marrow concentrate throughout the entire area of tendinopathic region. So if you guys haven't heard of the second generation and third generation ultrasound guided procedures, they are the present and the future. First generation is putting a needle somewhere and injecting. Second generation is cutting. And so your very own Jonathan Finoff, I don't know how much you guys work with him in Colorado Springs. I know he's faculty with you guys. He is one of the best resources in the world. He taught all of us ultrasound. And so ultrasound guided fasciotomy for anterior and lateral compartments, exertional compartment syndrome is very successful. I'm trained in that. Third generation ultrasound guided procedures, you guys may or may not have heard of because this is not widespread anywhere. And For the foot and ankle, it's the ATFL repair. And there's an institution in Japan that's partnered with University of Pittsburgh Medical Center that had 2 years ago, when I talked to my buddy Kentaro Onishi, they had done 20 humans, and this is led by foot and ankle surgeons. This is not physiatrist led. This is a foot and ankle surgeon led project. In my opinion, it will always be done by foot and ankle surgeons, but something that is coming up and appears to be successful with even shorter return to play for reasons I don't completely understand. But for those of you who don't have a lot of understanding or use with ultrasound, I'm going to go over the basics very quickly here. And the first main principle is that when you put an ultrasound on any part of the body, you get a credit card thin slice. So that means anything distal or proximal to where I have this probe, you don't see anything, only where the probe is. It's like taking one slice of an MRI or a CT. So there are two ways to do an injection. There's an in-plane and an out-of-plane. The in-plane, it looks like this, where your needle is in plane with the length of the probe, and then your out-of-plane looks like this. Now, as you can see with this picture below, all you see is a dot where the needle is. And then you see some acoustic shadowing below the needle on the ultrasound picture on the right. And what you see on the left is that that needle is way past the ultrasound probe, which means you could be right under your tip of your needle could be right under the probe. It could be a centimeter past. It could be a foot past. You don't know where your tip is unless you really look for it. So that is the main downside of an out-of-plane injection. It's really handy for midfoot injections. That's what I use almost exclusively for my midfoot injections. Once you get good at it, these become much more accurate. But at first, you don't know where your needle tip is, and so they are simply less accurate until you learn to find your needle tip, which should be done on a chicken or a turkey or something that is not a human. So when you're doing this injection, you start shallow and you slowly get deeper with your needle, finding your needle tip on your screen. And so this is what I use for almost all my midfoot and MTP injections. So the clinical pearl here is when you're doing an in-plane injection, get your needle as parallel to the bottom of the transducer as is humanly possible, which ends up being perpendicular to the ultrasound beam. And whenever possible in life, do an in-plane injection. Out of plane is a little trickier, a little less accurate. So more quick pearls before we get to the juice of the talk. Controlling the ultrasound probe is not easy. It's really important that so of course you have fingers on the probe. I don't need to tell anybody to have fingers on the probe, but having fingers on the patient with the probe hand is really important. Your pinky plus or minus your ring finger on the patient's foot or on the patient's body, because otherwise that probe will slide one way or another and you lose your entire view. Now, at the same time, with the other hand, you need to contact the patient with the hand that has the needle. And these are all ways to stabilize your needle and stabilize your probe, because there are two, your needle and your probe have to be in line with each other. So have at least one finger touching the patient or the table, something that is a non-movable object while you're doing this. So this is what this looks like. Close-up view, important things. You got a finger on the patient. You have a finger on the patient or the table with the other side. And if you do that, you will not have trouble keeping your probe and your needle aligned. Your own comfort is more important for this injection than doing a landmark guided injection. And this is called the straight line view, which means that your eyeballs, the patient's body part, and your ultrasound are all in a straight line. Then you just look down and up to see your needle back to the screen, needle, screen, and it happens really quick. If you have to look to the left or look to the right, this becomes very challenging, and it's simply harder to control your needle. It's hard to keep an eye on where your needle is below you while you're trying to look at the screen. Now that needle tip, you heard me talk about this in the short access view above, but any injection you do ever, it's crucial to keep the needle tip in view, to know what your needle is passing through. So this is one of my favorite injections there is, the FHL sheath injection at the level of the ankle. And there's the FHL, the sheath goes around it. There's my needle right under the sheath, between the sheath and the os trigonum. And then here's your tibial nerve. And so if at any point I lost my needle tip, it would be just too easy to slice through the tibial nerve. This is a big point, and I have an entire hour slide set just on this that I'm going to summarize in my next slide. So how do you find your needle tip? Well, look down at the actual needle, because sometimes when you're staring at the screen, your ultrasound probe will slide one way or another, and you'll realize, oh, I'm not actually, that credit card thin slice is a centimeter away from where my needle is. Move the probe left and right. Even if it looks right, move your probe a little one way or another, because the angle may not be directly downward to your needle like you think it is. And then wiggle the actual needle. I'm not talking big centimeter wiggle of the needle. I'm talking just a little vibration of the needle tip. It'll move the tissue, will vibrate the tissue around the needle and help you find your needle tip. Heel to probe, heel to toe movements with the probe. This is something that I can really only show you in clinic or in a cadaver lab, but this helps you create a more shallow approach for your in-plane injections. And for those of you, especially when you start, the needle guidance feature is nice. I don't use it anymore, but I've had my days where I had trouble finding the needle, and I did use it. The most important trick here of all of these is to be patient. The first 100 of these that you do will take significantly longer than if you're doing a landmark guided injection. And you just need to concentrate and focus and not rush. Once you get the hang of these, they get very quick, and obviously more accurate. The literature on these is for midfoot injections without, I know you guys are probably using fluoro, but if you're not, if you're just using landmark guided, we're talking somewhere in the neck, in the neighborhood of 50 to 60% accurate in making it into the joint. And if you're using ultrasound, somewhere around 90+% accurate. So patients will go a long way with that. And then don't advance your needle until you find the tip. Otherwise, you could be poking through cartilage, tendon, nerve, artery. So for those of you who are getting into orthobiologics, in my group, one of the first orthobiologic injections I've taught my foot and ankle partners is plantar fascia PRP. And you have to anesthetize. This is very different than putting any orthobiologic substance into a joint. But if you're going into a tendon, any tendon, an Achilles, a plantar fascia, posterior tib, whatever it is, any solid structure you're putting a needle into and injecting into the solid structure, you have to anesthetize. Now, there are two ways to do this. And when you're first starting, I suggest just take a few cc of 0.5% ropivacaine, because it is less tenolytic and tenotoxic and chondrotoxic than lidocaine or marcaine. Marcaine is the worst. Put a few cc of ropivacaine around the tendon at the time of blood draw, and then give that at least 10 minutes to set in, and then you can go back and do your injection. And often I'll put a 1/4 cc of ropivacaine into the tendon when I'm going around the tendon. Now, I prefer not to put any anesthetic around my tendon, because even ropivacaine has some small amount of tenotoxicity. So one of my research areas, paper we published a year ago, is a set of nerve blocks that work really well for orthobiologic procedures. For the plantar fascia, tibial nerve block just above the ankle works nicely. That's the picture on the right. For anything in the ankle and midfoot going into a tendon, a subchondroplasty even, a popliteal block does the trick. And for those of you who really get fancy with ultrasound, popliteal block is an easy thing to learn. So the easy injections, the first ones to start off with, these are the ones that are superficial, that have a shallow approach and long access. And these are going to be your ankle joint, your FHL injection, and I'll show you my approach for this because it's one of the funner ones that is tricky to do unless you use this approach that I did not create myself. Plantar fascia injection. These are all easy injections to do. The hard injections, now these are the injections that have a steep angle. Anything that's out of plane, until you get really good at those, anytime your patient has some challenging positioning and you can't get yourself into a good position, and an anxious patient. And I've done Dr. Hunt, and I first grew love for him because he helped me with my own foot. And so this is me doing my own midfoot out of plane injection, which is surprisingly not as hard as you would think, because you're thinking about the procedure and not the sting of doing the injection. But these harder injections, subtalar is more challenging. Your first few midfoot injections are challenging until you get the hang of it, and then they get really easy. So I'm going to just summarize. When I first, when Dr. Hunt first told me to ask me to give a talk on ultrasound for the foot and ankle, I said, well, that's great. Let me know which 2 full days I have to come in. And he said, okay, well, how about half an hour? So this is a very consolidated talk. I'm going to try to sum things up with 2 cases here, just to pull things together. The first is the principal dancer with the Kansas City Ballet, very talented gal. This is about a year and a half ago, about 2 years ago, she had medial first metatarsophalangeal joint pain. For 6 months, she failed everything. It was worse with anything point work. Anytime she was on an extended MTP that was loaded. 8 weeks in a boot with a toe spacer, she failed. We did 20 milligram intraarticular injection with Toradol. She failed. Of course, we used Toradol because steroid can loosen the capsule. And so at this point, we got an MRI. So her exam did show laxity on valgus stress tending the MTP, which reproduced her pain, and she was tender right at the proximal MCL. So we got an MRI, which showed this, a partial tear at the proximal MCL right there. So what do we do about that? Well, Kirk McCullough, being the head foot and ankle physician for the Kansas City Ballet, he and I talked with our physical therapist and with our dancer, and we decided at this point, let's try something that hasn't been published. It has been published on lots of other ligaments, especially the UCL of the elbow, with great results. So we did a leukocyte-rich PRP to this ligament. And so on dynamic ultrasound scanning, this dynamic scanning showed us something that you simply can't get with MRI, which is when you put that joint into a valgus stress, we got widening from about 3 millimeters to 4.1 millimeters. And so we injected leuk-rich PRP into the ligament, leukocyte-poor PRP into the joint. Since we've done this study, since we did this procedure, there have been a couple studies that have come out showing we could probably lose leukocyte-rich PRP for everything, including intra-articular. And this is what it looked like. So this is the day we did the PRP. There's my needle pathway. Now you can kind of make out my needle pathway. And then here is injecting into the mid to distal MCL ligament. And then here is injecting in plane beneath the capsule of the MTP joint. So this gal has the best follow-up medical care possible with since she's part of the ballet. She was in a boot with a toe spacer for 6 weeks, and then we got her into physical therapy. So at her 6-week visit, she came back. And so this is that first ultrasound image with the 4.1 millimeter widening on valgus stress. And at 6 weeks, she came back and her joint space was 3.3 millimeters. And then at 10 weeks, it was maintained at 3.3 millimeters. And at this 10-week follow-up, she was able to dance. She was pain-free, and she was able to dance fully in her next show. She got back to dancing a year and a half ago, and she's been full since. She now has some issues on the other ankle with posterior ankle impingement stuff, which 3/4 of our dance company has, but this toe at least is doing great. So that's case 1. Case 2, another dancer. This is an elite high school age dancer. She's a competition dancer, so not ballet. She's had 10 weeks posterior ankle pain, maybe the most common thing that I see in my clinic. It's worse with any point work, with any landing. Her exam shows a positive plantar flexion test. For those of you who aren't familiar, you basically forcefully bring their ankle into plantar flexion. And if there's impingement in the back of their ankle, if there's an os trigonum, a stieta process, or some other space occupying mass back there, it will pinch and create some impingement symptoms in the back of the ankle. Her FHL tendon at the ankle was tender, as was the posterior process of the talus. Her Achilles exam was totally normal. She failed 6 weeks of excellent physical therapy with the lead physical therapist for the ballet. So she came in for imaging, normal x-ray back there, no stieta, no os trigonum, no old fracture, nothing back there. So I put my ultrasound on her, and this is what we saw. This is at the level of the subtalar joint, and we see this muscle belly persisting. So now we do a sagittal oblique, which is in the best way that I have found to long axis image the FHL. And this is what we see. So left is proximal, right is distal. This is the ankle joint, tibiotalar joint. This is the subtalar joint. And the FHL is going from left to right, right above those structures. You can see the tendon, the aponeurosis of the FHL going from left to right, almost a straight line. And the muscle belly of the FHL extends to the subtalar joint and past the subtalar joint. And there's edema within the FHL muscle. You can see that arrow. It is a darker, less steak-like appearance of the FHL muscle, whereas the FHL muscle on the left side of the screen is less dark, and you can see individual fibers of the muscle belly. So at this point, we had a long conversation. Low-lying FHL is way more common than we think. The cadaveric studies show it's somewhere between 15 and 40% of humans have a low-lying FHL. Do we go right to debriding the FHL? Well, we tried an FHL sheath injection with 40 milligrams of depomedrol and a cc of ropivacaine, and it worked. This is the approach I was telling you about earlier. We go lateral to medial. We go under the Achilles tendon. This is the Achilles tendon. So the sural nerve is quite a bit farther anterior. If you hug the Achilles tendon, you're going to stay out of harm's way with the sural nerve. But that Achilles tendon, you go beneath it. And then this is your tibial nerve. You can see the nerve artery, so the artery and veins above the tibial nerve, superficial to it. And then you see my needle going right beneath all of those structures. This is, you put the patient in a prone position. This is one of the least painful positions because of the sensory innervation at the lateral ankle, and it's very safe, and a monkey could do it. Once you've done a few ultrasound guided injections, this is one of the sleekest things that I do in my practice, not because it's hard, but just because it's hard to get into if you don't use this technique. So back to our case, there's the FHL. Back to our case, she had immediate relief for diagnostic purposes. I had her hang out 30 minutes. And then we're now about 2 years out, and she's still doing better, which always makes me wonder if someone has an anatomic abnormality, how are they better? Well, we just got them back to the level of inflammation they were at before. So those are my 2 cases, and some other things that we can see with ultrasound, just to kind of show off what we can do, the power of ultrasound. We haven't harnessed the power of ultrasound. There's so much we still have to learn about it, but this is that red line, that red arrow is pointing to an os trigonum. This is a sagittal view with ultrasound. This is my favorite sagittal oblique view. There's an os trigonum. And then this view here, this is the axial view. This is fun because, so there's the talus, there's the os trigonum. Here's the FHL, and you can see the synchondrosis. And when you're injecting, if you put a needle and you're poking the os trigonum, you can see it wiggle. If that synchondrosis is not intact, you can see the os trigonum mobile. Here's a dynamic video of what is actually happening in FHL impingement. Now, again, this is something you can really only get with ultrasound, but you see the FHL, and you see that stiata, between that stiata process and the posterior tibia, you see that FHL being rubbed and actually being compressed. So we can see why and how this happens. So my favorite diagnostic test for FHL that we're in the process of writing up is a dynamic FHL. So you put them you put the ultrasound in an axial view, and then you wiggle your big toe. All we're doing with my left hand is I'm wiggling the great toe to create that FHL to move. This is the normal angle. And I see this on nearly every FHL symptomatic posterior ankle impingement. Is more sensitive than any other test. I just need to validate it. And so here's the normal side. Now you can see the difference here. I am moving that great toe just as much on the symptomatic as I am the asymptomatic side. And you can see that it is just simply stiff. We see this all the time. More powers of FHL. Well, pretty much every soft tissue anomaly of posterior ankle impingement can be seen with FHL. It's user dependent. Got to know what these things look like. Posterior intermalleolar ligaments, for example. I love them, but it's something that people usually fall asleep when I start talking about. So we're finishing up here. How do you get involved with ultrasound? Well, your first step is to practice, of course. When you inject, start off using lidocaine, which you don't always do with fluoro or landmark guided injections, but absolutely do it because you're going to, your first 100 injections are going to take longer, and this is going to be a better procedure. Use a probe covering sterile gel for your first 100 or so, and then I showed Dr. Hunt a way to wean away from that very safely. And then I love turkey. You get a raw turkey. Turkeys have all of these joints that anatomically are not similar, but on ultrasound, they look similar to the midfoot. And it's really great practice for an out-of-plane approach. So get a turkey, get a whole turkey, and just start putting needles in places with ultrasound. This is the book I suggest anyone get, John Jacobson's book. There are so many workshops. This is one that I direct, the ultrasound workshop for Toby. It's in 3 weeks. It's awesome. It's amazing. We have some of the world's best ultrasonographers teaching this course. And then once you've done these things, just practice, 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 practice. Thank you for having me, Dr. Hunt. I don't know if we ran out of time, but if we have time for questions, I'm here.
Yeah, Mike, that was really, really good. Thank you. Thank you so much. Any questions from the group? So that was really good. And I think, you and I had talked about this, potentially having you come out for like for like a little mini course. Because I know a lot of this, obviously you've shown us a lot of the intellectual part behind it, and your technique is great, right? And so that's something we can practice, but actually practicing with someone like you who has the knowledge would be useful at some point, that or attending one of these workshops, which I'm assuming would have a practical component, like a practice component. I don't know whether that be on models or if you bring in a bunch of turkeys or practice on each other or on yourself, right?
Yeah, I think the best. Yeah, I'd love to. I'd love to come out. I think the best. So the problem with workshops is it's one day. It really should be 2 days, about 3 to 6 months apart, so you can practice in between. Because the learning curve, it's really wild. Your synaptic connections, it takes a while to really figure out how to hold the probe, how to hold the needle, all that stuff just takes some time. But yeah, let's talk.
Yeah, great. And for those who are thinking about, sort of adopting this, all of our clinics have ultrasounds, and I think they're relatively high quality because our PM&R and sports med teams like really do a lot of this. And so, there's no harm in that, right? It's a really nice diagnostic tool, and you can bring it in, even if you're not going to start with guided injections, bring it in to evaluate the tissues. Like you'll have an MRI maybe, and you can say, hey, I want to get a little dynamic look. And it's a really useful tool. Patients appreciate it because they can see it and you can point it out, just like Mike did today, on the screen, like this is what's going on. So, but it's a really nice tool. I don't know if it was your year or not, Mike, but I remember one of the visiting team physicians brought an ultrasound with the team, and he said, yeah, we don't do x-ray unless it's like it's something in the pelvis, but I can diagnose everything I need with ultrasound. So fracture, tendon problem, he's like, we don't use x-ray, like we just bring this ultrasound everywhere we go, and that's all we need. Which has some benefits,
especially the foot and hand. There's some really good literature on stress fractures even in ultrasound. It's more sensitive than x-ray, which isn't too hard to beat, but for stress fractures, even without a break.
Yeah. Well, excellent. Thank you again. Really, really appreciate it.
Yeah. Thanks everybody. We'll be talking.
Have a good day, everyone.